all for coming today. So the topic today is fatty liver. Not all fatty liver created equally. So there's nothing to disclose. So we're going to start today with our objectives. So we're going to define NAFLD and its subtype, discuss the epidemiology and natural history of NAFLD. So how common, what's the highest group of having NAFLD and NASH. We're going to review the NAFLD diagnostic strategies, and finally we're going to discuss the management modalities. So what is NAFLD? So basically it's the presence of fatty liver or hepatic steatosis either by imaging or histology and the exclusion of other causes of liver diseases, mainly alcoholic liver disease. It's subdivided in two categories, NAFL, which is simple steatosis, and NASH, which is steatosis and inflammation, regardless of level of fibrosis. So overall, when we have patients with the fatty liver by ultrasound, by imaging, either it's falling into the category of NAFLD NASH, in the context of metabolic syndrome, this is the topic of discussion today, or secondary, as we see in other conditions, such as medications, steroid, amiodarone, tamoxifen, heart medication, HIV therapy, as well as in the context of TPN, bariatric surgery, starvation. And also we see fatty liver steatosis in other particular conditions, such as hepatitis C, genotype 3, Wilson's disease, and alpha-1 antitrypsin deficiency. So the topic today will be primary NAFLD NASH in the context of metabolic syndrome. There are other acronyms that we use for steatohepatitis. So NASH, non-alcoholic steatohepatitis, topic of discussion. ASH, which is alcoholic steatohepatitis. BASH, which is both alcoholic and non-alcoholic steatohepatitis. DASH, which is drug-induced steatohepatitis. And CASH, which is chemotherapy-associated steatohepatitis. It's interesting acronyms. So if you look at the definition of NASH, of NAFLD, so I like the European definition, but it's because it includes insulin resistance as part of the diagnosis or the definition. So do you have a pointer here, or doesn't work? Okay, I'm sorry. So we have the European definition of the insulin resistance as part of the definition. That's European definition, and they fall into two categories: NAFL and NASH. And we see NASH here; it's steatosis with inflammation and ballooning. So NASH per se is histological diagnosis. And within NASH, we have two categories. We have early NASH and fibrotic NASH. So fibrotic NASH is having steatosis, inflammation, ballooning with significant fibrosis, F2 and beyond. Why it's important to recognize the fibrotic NASH? Because this is the one we're going to progress further to cirrhosis and related complications such as HCC. So if you look at the definition of NASH, it's histological diagnosis and requires liver biopsy. So the spectrum of NAFLD, so we have NAFL, NASH, fibrosis, cirrhosis, and complications such as HCC. And as we mentioned previously, steatosis is having just fatty liver with minimal inflammation. And steatohepatitis, which is histological diagnosis. But I want to mention here that when you have a patient that comes to see you in the clinic and with fatty liver in ultrasound, there are some predictors of presence of NASH. So we have by ultrasound steatosis, and there are some predictors of presence of NASH that include metabolic syndrome, advanced age, sex, and race. There are also predictors, mainly the persistently elevation of ALT, that suggests that patient may have NASH. Reversal of ALT-ALT ratio and low platelet are more suggestive of advanced fibrosis. So you see the circumstain, the fibrosis here, as well as here you see the ballooning, hepatocyte ballooning. You see some inflammation, and as we know, the fibrosis, there are 4 stages with the bridging fibrosis stage 4, fibrosis or cirrhosis. So as mentioned, fibrotic NASH is very important to recognize because this is the subtype that progress further to cause cirrhosis and HCC. If we look at overall patient with NASH, 20% they will develop, they will progress beyond to cirrhosis. And we have a third of patients with NASH can progress from one stage to another every 7 years. This data is very interesting because it's not necessarily a linear progression, as we're going to see from further slides on the next topic. So I would also to mention that hepatocellular carcinoma, the incidence of HCC in cirrhotic patients is around 2.5%, and you can develop HCC without having cirrhosis, similar to hepatitis B. The guidelines, they don't recommend to screen for HCC on patients with NASH without appropriate, without staging of fibrosis, without having cirrhosis. So how common NAFLD? If we look at the general population, there are a significant number of patients with NAFLD in our population, and there are clear correlation between the obesity prevalence as well as prevalence of NAFLD worldwide. If we look at US population, if we just take ultrasound, almost half of the population will have some evidence of fatty liver by ultrasound. Patient with obesity, there is clear correlation between higher BMI and presence of NAFLD. But most alarming is the patient, the healthy donors. For living donor transplant, for transplant, 6 to 15% of patients, they may have NASH. They are reported as healthy living donors. So yes, NAFLD is very common, and there are some groups with high risk, mainly high BMI. Most important group is the diabetes mellitus patient, diabetes type 2. Regardless of the tools that we use, so the prevalence of NAFLD in diabetes is much higher compared to general population. If we look at controlled attenuate parameter, which is a FibroScan, that I'm going to discuss later on, so 70% of patients, they may have fatty liver by FibroScan. Now, if we take patient with normal EST and ALT, patient with NASH, patient with normal AST and ALT, and diabetic patient, the prevalence of NAFLD increased based with good correlation with increasing BMI. So for BMI above 40, almost 90% they will have NAFLD. So those are patients with normal AST and ALT. In this cohort of 103 patients, the biopsy was made, and 56% of patients, they have NASH. Again, I think this cohort, they have higher than expected patient with NASH. So this is meta-analysis to assess for advanced fibrosis with NASH patients. So if you use FibroScan or NAFLD score, this is meta-analysis of almost 3,200 patients. The prevalence of almost was 20% prevalence of advanced fibrosis. So clearly, diabetic patients have higher prevalence of NAFLD and NASH, and particularly fibrotic NASH. Now, if we look at overall, we put things together. So the patient with NAFLD or NASH tend to be obese with diabetes, dyslipidemia. It happened that those are also the risk factors for cardiovascular disease. And for this reason, we believe that NAFLD is the hepatic manifestation of metabolic syndrome. And we believe also that insulin resistance is a driver for this, is the driver pathogenic factor. So NAFLD is very common. If we put number in perspective, so if the population of the United States is, is 300 million or so, we believe that potentially we have almost like 0.5 to 1 million people with NASH cirrhosis, and they're underdiagnosed. So what is the impact of NAFLD in our population? This is data from Ohio, so up to 2012. This is the patient that are listed for transplant. We see there is increasing trend of patients listed for transplant with NASH cirrhosis, while there is decreasing trend for patients that are listed because of hepatitis C. By 2020, we believe that those two lines are going to cross, and we're going to have more patients listed with NASH cirrhosis. Also because of the advent of the new DAA, direct acting antiviral therapy. So in regard to HCC, in 2002, we had The etiology of HCC was mainly hepatitis C and NASH, with only 2% was NASH-related HCC. By 2017, we have almost 18% of etiology of HCC related to NASH cirrhosis. So what about mortality and NAFLD and NASH? So the major cause of mortality in patients with NASH, it's not liver-related complications. As mentioned, we believe that NAFLD is the hepatic manifestation of metabolic syndrome, and the major cause of mortality is cardiovascular and extrahepatic malignancy. So the liver-related complication is the number 3 as etiology of the mortality of those patients, or cause mortality. So why? What's the reason for all this progression from steatosis, NASH, and cirrhosis? We believe there are major 2 modifiers. One is related to environment, sedentary lifestyle, excess saturated fat, high caloric intake, excess fructose, processed meat, and also the gene, PNPLA3 and TMS6SF2. I would like to mention here that those modifiers that can also explain why there are disparities among subgroup population. We believe that African American, they have the allele of PNPLA3 that's protective, while Hispanic, they may have more prevalence of mutation of that allele. Also, we have some group population where they have some more mutations, some family with more mutation, and they will develop NASH cirrhosis. So yes, this is also we point about, we can probably discuss about lean NASH. So those are the patients with the NASH without having metabolic syndrome, and we believe that the reason for them to develop NASH is mainly related to genetic mutations. So if we look at the NASH pathogenesis, from hepatology, so we have a simple way to try to explain why we have fatty liver in the fatty acid in the liver. So we have 2 ways in, which is from dietary and the adipose tissue. So we have fatty acid getting into the liver, and 2 ways out, through either storage as triglyceride or beta oxidation. So 2 ways in, fatty acid or dietary adipose tissue, and also the carbohydrate to de novo lipogenesis. So we have fatty acid get into the liver and get stored as triglyceride. So if you block this pathway, that has been done previously in animal models, the liver enzyme if we do biopsies after we block this pathway, we were not going to see any fatty acid in the liver. However, in the animal model, we found out that ALC went up to 1,000, and then the mother died because of liver failure. We believe that if this triglyceride storage is a buffer mechanism and it's protective mechanism. As such, if you block this pathway, we have more fatty acid going towards oxidation, and then mainly macrosomal oxidation, development of lipotoxic molecule, inflammation, NASH, steatohepatitis, stimulation of steatosis cell, eto cell, fibrosis. So I believe this oxidation is the major driver of the pathogenesis in NASH. So what happened in patients with diabetic insulin resistance? There is dysregulation of hormone-sensitive lipase with more influx of fatty acid, with the downregulation of beta oxidation, and we have more macrosomal oxidation and development of inflammation and NASH. So if we truly look at the pathogenesis, it's much more complex than that. So there are so many variables, as we mentioned previously, genetic, environment, also the microbiota that affect the bile acid. So it's very complex. And those pathways, any pathway here can be the target of molecules, or therapeutic molecules. So what happened in fibrosis at NASH? So what's the rate of progression? So this is a similar study that show that both NAFL and NASH could progress, and this is meta-analysis of 11 paired biopsy studies, and show that the rate of progression, 1 stage every 7 years. But it's only happening in 1/3 of the patient. With the NASH, that's progress 1 stage every 7 years. So that's clinically significant. So this is a study from a late Dr. Angulo. So they compare patients with the NASH with and without fibrosis, And they found out the most predictive factors of mortality is the presence of fibrosis. So fibrosis stage was associated with overall mortality, liver transplant, and liver-related events. So NASH and fibrosis, or fibrotic NASH, is very important to recognize. So as we mentioned previously, there are some predictors of presence NASH in the patient with just fatty liver, like NAFLD. So there are sex, postmenopausal women experience accelerated disease, metabolic syndrome, persistently elevation of ALT, and advanced age, which is reflective of greater duration of the disease. So race also there are differences. So we believe that patient Hispanic and the Caucasian, they are higher prevalence, as well as Asian, but African American less likely to have NASH. So clearly the NAFLD is very common, but we have fewer patients that develop fibrotic NASH, which is a stage beyond the simple steatosis. The fibrotic NASH is clearly associated with advanced disease, as well as higher mortality and morbidity. So for as outpatient, when we see patient with fatty liver, we have two questions that we ask ourselves. Number one, is there NASH? Is there any inflammation? Second question is, how much fibrosis is there? Another way of saying it, we need really to that if the patient have fibrotic NASH. As we saw previously, the fibrotic NASH is the one who's been associated with higher mortality and morbidity. So there's the two questions that we ask. So how we achieve that? So basically, patient present to see us, they're generally asymptomatic. They may have mild elevation liver enzymes, fatty liver and imaging. They may have hepatomegaly and report fatigue. So the patient is often asymptomatic. Sorry. So this is a protocol that we often follow. This is from European guidelines. So basically, we rule out any associated liver disease and assess for alcoholic intake. So less than 20 grams in women or less than 30 grams in men. So another way of saying it, less than 21 drinks in men and 14 drinks in women. We assess for any aspect of insulin resistance or metabolic syndrome. We rule out viral hepatitis. For patients that with no evidence of insulin resistance by history, we start thinking about rare conditions such as Wilson's, autoimmune, alpha-1 antitrypsin. So this is from a European guideline. So there are multiple tools that we use. So basically, we try to identify patients with fatty liver with the NASH phenotype. Another way of saying it, there are clinical characteristics as we saw from the epidemiological data that the metabolic syndrome, diabetes, higher BMI, and Hispanic. So the ethnicity play a major role. And also we use what we have as tools, what is non-invasive methods of fibrosis evaluation, such as LabRock, FIB4, NASH fibrosis score, and FibroScan. So the NASH phenotype is basically when patients come to us, we try to identify metabolic syndrome, as we're familiar with. Patient with NASH most likely will have a fatty liver in the context of metabolic syndrome, diabetes mellitus, persistently elevation of liver enzymes, older age, and higher BMI. So the question, initially when we start with definition, we talk about the role of biopsy. And we mentioned that NASH is histological diagnosis. The question, do we need to biopsy anybody that presents to us with the fatty liver? The answer is no. So because of the non-invasive method of evaluation fibrosis. So the non-invasive methods could allow us to reduce the need for liver biopsy, and they also allow us for longitudinal follow-up. So aside from diagnosis, it allows for longitudinal follow-up after therapeutic intervention. So the non-fibrosis tools fall into two categories: the lab work and FibroScan, or show-wear elastography ultrasound, or MRE. So I'm going to talk probably about the NAFLD score. It's very interesting score and also easy accessible in your computer, NAFLDscore.com. So basically, you put all the numbers together. age, BMI, presence of ACLT, and platelet albumin, and you calculate the score. So the score, as mentioned, includes all those parameters, and in addition to the metabolic syndrome aspect, insulin resistance. Also, there is a FIB score; they are equivalent. I would like also to mention that aside from the lab work that can give us an idea about fibrosis, there is the FibroScan, which there are two measurements: kilopascal, which measures liver stiffness, and CAP, what measures steatosis. So if we look at the diagnostic performance of those tests, as mentioned, the goal is to diagnose fibrotic NASH. So we're going to focus on the performance of the test based on in the context of advanced fibrosis. So for NAFLD score, as mentioned, it's easy to calculate using a computer. So there's two cutoff, less than minus 1.45, and above 0.67. So minus 1.45 suggests for low fibrosis, and above 0.67 suggests for advanced fibrosis. So for the performance of this test, the negative predictive value of the NAFLD score is 92% for low fibrosis. Another way of saying it, when you have low numbers, you are almost confident that you do not have advanced fibrosis. So it's a good test to exclude advanced fibrosis. So negative predictive value is 92%. However, positive predictive value is 67%. Another way of saying it, if you have score that's above 0.67, you will be wrong in third of cases. So those patients may need liver biopsy. Another problem with the NAFLD score is the gray area. So it's almost 30%. So let's compare that to FibroScan. So FibroScan, the negative predictive value is 96%. So when you have score below 7.9 kilopascal, you are very confident that you do not have advanced fibrosis. Striking about FibroScan also is the gray area, is only 15%. When you have advanced fibrosis, the positive predictive value is 68%. You're going to be wrong in third of cases. Those patients may need liver biopsy. So the test is the non-invasive methods, they are very good to exclude advanced fibrosis and less accurate to diagnose the presence of advanced fibrosis. So it's mainly because of the good negative predictive value. So combination of tests, we can do that, combination of FibroScan with lab work. However, we end up with almost more than 50% of patients on the gray area with no accurate diagnosis. So as mentioned previously, FibroScan, the fibrotic NASH is very important to recognize, as this is the one who's associated with more advanced disease, and we can intervene, and we intervene at that stage more aggressively. So if we look at the all clinical trials that's ongoing right now, so the fibrosis, all the inclusion criteria is a NASH, fibrotic NASH with F2 and beyond. Another way of saying it is that when you have medication, when the medication is going to get approved, it will be based on those inclusion criteria, and we approved for patients with F2 and beyond. So that showed the importance of fibrosis evaluation. So currently we do have two of those studies at Metro. We have a Regenerate trial as well as Aurora trial. So this is algorithmic approach, so basically the screening in high-risk group in diabetic endocrinology clinic. So this is European guideline. They do recommend screening for fibrosis. American US guideline, ASLD, WSLD guideline, it's not clear at this point because they mentioned that there is no FDA-approved treatment. We may disagree about that aspect. But the idea is that they recommend strongly evaluating fibrosis in patients with high-risk factors. So, as mentioned, there is no FDA-approved medication. But the key here for the management is lifestyle modification with the weight loss, diet, and exercise program. So if the patient comes to see you in the clinic and you're just advised to lose weight, this is a study from 2007. But it's very interesting. If you just advise them to lose weight, you will not be that successful. There's almost nothing going to happen. There will not be any weight loss. So that shows the importance of a multidisciplinary approach referred to nutritionist or weight loss program. So what happened to weight loss on NASH? So it's clearly weight loss has been associated with with improvement of steatosis, fibrosis regression. And we believe that the cutoff number is 7%. Weight loss more than 7% is associated with improvement, fibrosis regression. And most importantly, weight loss of 10% is associated with fibrosis regression. Even further than that, bariatric surgery. So they evaluate fatty liver and NASH, and they found out that NASH resolution can happen up to 85% at 1 year after surgery. 43% of regression of fibrosis at 1 year also was noticed. So what about what diet we need to use? Is it reduced fat or reduced carbohydrate? So regardless of the diet we use, as long as it's hypocaloric diet, there are significant improvements of ALT, as well as decrease on intrahepatic lipid content. This is a recent study. So the diet was isocaloric diet, was not meant to lose weight. So they had high protein diet. Just with high protein diet, there was decrease on intrahepatic lipid profile. So intrahepatic lipid. So they are not necessarily hypocaloric, but just isocaloric diet. So there was no intention on using energy restricted diet. So high fructose. This meta-analysis showed that high fructose has impact only when patient on hypercaloric diet. If the patient is following isocaloric diet, there was no impact on fructose consumptions on developing fatty intrahepatic lipid, intrahepatic-cellular lipids. Just want to mention here this meta-analysis about exercise independent of diet. So exercise does improve ALT in NAFLD NASH patients. It does decrease intrahepatic triglyceride. This is independent of weight loss program. And clearly, diet plus exercise does improve non-alcoholic steatohepatitis score, like inflammation score. Why I brought this slide just to show that for patients with lean NASH, so we don't have necessarily to follow a weight loss program, but just exercise per se can also help patients with lean NASH. So this is an interesting study that was they assessed Mediterranean diet and they compared that to low-fat diet. And interestingly, as we see with often weight loss program, there is weight loss at 6 months and with slightly increase after that. So this study, the aim was to correlate the diet with the fat deposition in every aspect, in the cardiac fat as well as liver. So Mediterranean diet did better comparing to low-fat diet with less deposition of fat at 18 months. So yes, for Mediterranean diet, there are data that show that it seems to do better for NASH patients. But I also mentioned that Mediterranean diet is not only about diet, it's a lifestyle because it involves physical activity and the way we have our meals. So from the data from Villar-Gomez, so it showed that the weight loss is the key, and the 7% is the key number of weight loss, with NASH resolution noticed when there is more than 7% weight loss, and significantly when you have more than 10% weight loss, fibrosis regression. So, but if you look at old patients, we found out that only 10% of patients were able to achieve this 10% weight loss. So when we get to medication for NASH, there's no FDA-approved medication. Multiple drugs have been studied, but I just want to mention the Prevalence trial, probably you may be familiar with, is vitamin E plus pioglitazone versus placebo. So this trial does show improvement of NASH, however, no effect on fibrosis. So yes, it does improve NASH, but no effect on fibrosis. So I would like to mention that vitamin E, since then, there was multiple studies that show that probably there is high risk of mortality or high risk of developing prostate cancer. So there is less, there's been less used at this time. So since this study of Prevalence, so Prevalence trial was done in patients that they are not diabetic, and the patients with cirrhosis were excluded from the trial. Since then, there were these studies recently published in Clinical Gastroenterology and Hepatology Journal, and they compare a prospective study. They randomized patients to group pioglitazone or placebo, and they've been followed for 18 months. So the patients, they were diabetes and pre-diabetic patients. So pioglitazone did improve NASH in both groups, including pre-diabetic group. In addition to that, pioglitazone does improve fibrosis. However, was not clearly, despite the statement here, was not clearly significant, maybe because of the sample. So pioglitazone, according to the author of the article, should be used in the context of NASH and diabetes. I would like to mention the AASLD guideline, they don't recommend, they don't comment about using pioglitazone. So this study, as we're talking about lifestyle modification, this is the Khallafi conception. So this is the umbrella review of meta-analysis. So this is the mother of all meta-analysis. So, so it showed that Khallafi does improve the chronic liver disease. Interestingly, on this study also, it showed that lung cancer, there is higher risk of lung cancer with Khallafi. Again, after correcting with after correction of confounding factors such as smoking, this statement is not valid any longer. So yes, clearly Khallafi does improve chronic liver disease. So overall, if we look at lifestyle modification, the data that we have so far is that Mediterranean diet does improve NASH NAFLD, and the key goal for weight loss is 7%. So so if we look at this is an algorithm that was published in Diabetic Care. So basically, for patients with diabetes and NASH, they recommend to use pioglitazone and the lifestyle intervention with the goal above 7% weight loss, 8 to 10%. And if there is failure of achieving the goal, they recommend metabolic surgery. So while we're trying to achieve, while we're trying to treat NASH, we continue to control our cardiovascular risk factors. So this is the AASLD guideline. So basically, they don't recommend bariatric surgery initially. So the statement, they think that it's probably premature to consider bariatric surgery as an established option to treat NASH. This is a US guideline. If you look at European guideline, it's a little bit different. So as they offer bariatric surgery as treatment in patients unresponsive to lifestyle changes and pharmacotherapy. So we mentioned previously the pathogenesis of inflammation is very complex, and there are many pathways, and any pathway can be target of a drug that's currently in development. There are so many drugs in development right now. So there are some that target insulin resistance. Pioglitazone, we saw the small clinical trial, the last clinical trial with pioglitazone. There are others that target inflammation, like CVC drug. So currently at Metro, we have a few clinical trials. It happened that I'm the principal investigator for those trials. So we have a Regenerate trial, and we have Aurora trial at Metro right now. So this is probably the last slide. Before the last slide, I just want to mention here that this is a recommendation on diabetic care. It's an algorithm for endocrinologists and primary care physician. So this is patient with diabetes. So we mentioned previously that it's very important to stage patient with fatty liver. So emphasis is on assessment of fibrosis. So according to this algorithm, so any patient with abnormal ALT or abnormal ultrasound with steatosis, they should have fibrosis evaluation, either by lab work, fibrosis biomarker, or by FibroScan. Even if you have normal ALT and EST, if you have patients that have uncontrolled diabetes or other uncontrolled other factors of metabolic syndrome, those patients should also undergo assessment of fibrosis. It just showed that any patient with diabetes probably should have fibrosis evaluation. And also, they also discuss about when to refer patient to hepatology. This is an algorithm that was published in Diabetic Care in 2017. So summary, so NAFLD is extremely common. 25 to 30% population, they have NAFLD. But the most relevant subtype is NASH with fibrosis or fibrotic NASH, because it's associated with higher potential to progress to advanced disease, cirrhosis, and HCC. It's important to organize to stage the disease by a non-invasive method as first step, and after further discussion with patient, we may consider liver biopsy. The key treatment at this time is still the lifestyle modification with diet, exercise, and weight loss program, and the goal is to lose 7% of weight. There is no FDA-approved treatment, and also it's clearly the importance of multidisciplinary evaluation with close evaluation with the involvement of endocrinologist, pediatric, weight loss, and nutritionist. Thank you. So, any question?
What is the recommendation for petoxifylline?
So yeah, so petoxifylline, there was one center here in Cleveland, they used petoxifylline because there was one study done at Cleveland Clinic that showed some positive results. However, further studies with higher number of population, higher cohort patients did not show any negative study. So we don't use petoxifylline. There's only one center, I think, based on one study that they're still using it in some population. Yeah.
So you're in the hospital and you're ready to discharge this patient, and you got a scan on the patient that shows some fatty liver, or your EPA needs to be fine in the scan. At what point do you, as a gastroenterologist, want to see them to not overwhelm your clinic? Because 25% of people have NASH, so it's going to be a lot of people seeing you.
Exact. This is a really good question. So to answer this question, so the European guideline tried to answer this question particularly. So this is why we need to identify patients with the NASH phenotype that potentially they can have NASH. So in Europe, particularly in the UK, they do non-invasive evaluation, fibrosis evaluation before they refer patient. So they do like either lab work with the NAFLD score or even FibroScan. They have access to that. So if you have no advanced fibrosis by FibroScan, you're confident 92% the patient does not have advanced disease. So those patients, they don't need to be referred to the hepatologist. However, if you have any other result or persistently abnormal ALC, those patients, they need to be referred to a hepatologist.
And when do you repeat doing the testing?
So it's a really good question. So this is basically the question is about longitudinal follow-up when we repeat testing. So if you're confident, we know that progression from one stage to another is 7 years. 35%. There's a rapid progressor and slower progressor. So if you control your environment, you control your driver of the disease. So there is going to have less likely faster progression. So the European guideline, they do like 2 to 3 years repeating testing.
Does it have to be the same test that you do, like FibroScan?
For the FibroScan, if you have access to that, that's fine. Again, it is so you can repeat FibroScan every 2 to 3 years. Yeah.
Have hepatitis C and hepatic steatosis, and you clear their hep C. How do you know if the fibrosis that's there is from the steatosis or the hep C? Do you biopsy those people?
So yeah. So how to manage the patient that they have combined disease like hepatitis C and steatohepatitis. So we know the genotype 3 is well known to cause steatohepatitis, but also we know that if you cure hepatitis C, the ATO cells are primed. So another way of saying it is that any injury down the road, they will have more accelerated process. So this is why even we cure hepatitis C, we tell patient, okay, you need to follow up with us, because if you don't insist about lifestyle modification, if you go back to alcohol, or you have overweight with the evidence of metabolic syndrome, those patients, they will have more advanced disease. It's not practical to biopsy all the patients after treatment. That plays the role of using non-invasive methods. So if you have a patient who was treated for hepatitis C, we insist about lifestyle modification and maintaining healthy lifestyle. We can proceed with FibroScan as baseline after 1 year or so, not initially after the treatment. Then that's going to be your baseline that you follow down the road for longitudinal follow-up. If the patient have low fibrosis score, or assuming by FibroScan it's less than 6 kilopascal, so you are almost 92% confident that the patient does not have advanced fibrosis. You may repeat after 2 to 3 years non-invasive method. Thank you. Any questions? Okay.